briefly, my name is Eckhard Teschner. I'm a senior product manager for the last 20 years for Pulmovista. And so I have accompanied the development of EIT, also together with Marcelo Amato, for the last 20 or even more than 20 years. My first question is if you would mind if I take off my mask, because then the communication is better, and I think we still can maintain social distance even for the first rows here. Okay, thank you very much. Okay, so the agenda, I would like first to provide you an overview, because that has changed over the last few years, what kind of clinical information EIT can actually present. And it might be much more than you would expect. I also hope that Marcelo Amato is coming soon, because he might also add some further clinical information that can be provided. And of course, to me, it would also be interested to see how the one technique or the other technique is presenting this information. I'm in contact with Marcelo Amato since very many years, also to make sure that the different devices, the different EIT devices, present at least comparable information, because I think that is very essential for introducing a new technology like EIT, which is initially at least a little bit complex to understand. And so I really hope that he is joining here, because we can then also compare the way we are assessing EIT data with each other. But right now, I would start giving you a little overview. And as you can see, I already assembled some images from the different devices, from the different technologies. And I say, just for you, welcome to the colorful world of electrical impedance tomography. Okay, so many colors, lot of clinical information behind that. And at the end, I hopefully you will see and realize how much use you can take from this different type of clinical information. So actually, I could say when I was preparing for this workshop, there was a preparation time of 21 years, because actually the first visit that I planned for Sao Paulo was already 21 years ago. I was by accidentally even at my birthday. And that was an email that I received from Marcelo Amato when we were already talking, having initial talks about a cooperation with each other. So that was planned. Then, as so often, things are going into different directions. So we collaborated, but of course not somehow in the same company or not with a very close collaboration. But I would say that apart some other people, Marcelo and I, myself, we probably have defined how electrical impedance tomography is really designed in the systems of today. That much as an introduction. So 21 years of preparation time to come to this visit. But now I'd like to focus on the role of electrical impedance tomography, or I understood in Brazil it's called TIE, in respiratory therapy. So first, when we just review very quickly, hi Marcelo, when we review very quickly the general goals of respiratory therapy, and I'm sure you all know that, of course, we want to achieve and maintain an acceptable gas exchange. But there's more and more evidence that we have to maintain lung protective ventilation, because if we have different conditions that cannot be easily detected at the bedside so far without EIT, there's always a risk that we are having, adverse effects like overdistension, cycling opening and closing, and collapse. And so when we just take a little look on a trumpet player, Dizzy Gillespie, a famous jazz musician that is still alive, even though he is creating expiratory pressures of up to 250 millibar. So that means, apart from the fact that, of course, while playing, he is making his chest wall extremely stiff, so the lung cannot expand. The second information behind that, and the second reason why he survives this extensive pressures, it is that, as has been demonstrated by a CT scan, when you have lung inhomogeneities, like in ARDS patients, you always have these little transition zones with very different mechanical properties. And in those transition zones, you can create mechanical stress to the lung tissue that might be 3 or 4 times higher than in a homogeneous lung. And that is basically here represented by those red spots in the images. So 2 reasons why this guy survived playing trumpet. A very stiff chest wall, but that's another story. That's not the story of today. But also very many lung inhomogeneities that he did not have while playing trumpet. So when you just take a schematic look on a chest CT, you very often see that the ventral part is at risk of being hyperinflated, and hyperinflation means lots of air, so a high local lung volume, but in contrast, because it's like a balloon that is almost overstretched, the compliance, the local compliance is decreased. That's always a combination. Large lung volume, low tidal volume. Then you might have a remaining area that is kind of normally ventilated. Then we have a dorsal region that can be collapsed or condensed. And then this might be displayed in white color in the CT scan. And then the transition zone between collapsed lung regions and this normally ventilated lung regions, we tend to see the effect of cycling opening and closing, which is when the PEEP is higher or lower than the opening pressure. So only during the inspiratory time, the lung opens up in order to collapse during the expiratory phase. So with ERT, just by presenting the regional ventilation distribution, sometimes we can always see directly in those images the effect of hyperinflation, which means due to the low compliance, basically no ventilation takes place in the affected lung regions. In contrast, we see dorsal lung collapse, where there's also no ventilation as a result, so no lung volume and also no ventilation taking place. And then we also have some yellow regions, and those yellow regions might be quite new to you. So this is kind of an indicator that those regions, which are typically located next to collapsed lung tissue, are those regions where we have a very late filling of the lungs and a very early closing. And when we also see a Peep Dependency, that is suggesting cycling opening and closing. So these 3 conditions can be directly displayed with electrical impedance tomography. And now coming to this clinical information and overview, and maybe Marcelo will be able to add more to that, certainly, I'm sure. But I just wanted to introduce a very old concept that I think even old ERT prototypes already applied, like 15 years ago already, which is that you basically create this cross-sectional ERT images, and then you subdivide it, for example, into 4 quadrants. And if you do that and you add the first 2 quadrants and compare it with the dorsal quadrants, then typically you should expect to get a ratio of 1:1. But I should also say that is depending very much, A, on the body position, and B, also on the position of the belt. Because if you put the belt lower in the mediastinal region, then the ventral part, of course, receives less ventilation, because then there's large space occupied by the heart. And so then this ratio is not true anymore. And I should also mention that this ratio, of course, only applies to the healthy lung. Right? Okay, so this kind of information is obvious. It is used by the different technologies that are available on the market. And when you then compare the left lung with the right lung, and we know that the right lung is a little bit larger, so that also matches with what we typically see in the healthy lung for ERT. If we compare the right lung with the right lung probably receives between 50 up to 60% of the ventilation. Then we can also subdivide an ERT image into ventral and dorsal layers, and that is what we typically like to do when we are looking on gravity-dependent effects, for example, during, when comparing supine with prone position, but also during PEEP trials. because then we can be a little bit more specific to the very ventral and the very dorsal regions. Yeah, and then we can typically expect to see, maybe 10% in the ventral part and 10% in the dorsal part. And again, that only applies for a healthy lung. Now, here comes the first difference or the first challenge for the ERT. When we have an obese patient, you can imagine an obese patient, there's a lot of tissue around the lungs. The image is always the same size, independent from the size of the body. And so then we had to have the ventilated area projected in a smaller area, right? So, and very easy to understand when you compare the CT scan from a slim patient with the one from an obese patient, there you also see that the ventilated or the lung tissue is capturing a smaller space, obviously. So when we subdivide such a region of interest into quadrants, it doesn't really matter. You know, in both cases, more or less in an even ventilation distribution, every quadrant should receive more or less 25%, maybe plus minus 5%, but certainly not much lower than 15% for any kind of quadrant. And the same applies for an obese patient. If you just look for this ratio between the ventral half and the dorsal half, you also can assume that we get comparable results. So also obesity does not affect this ratio. However, if we subdivide into 4 layers, to be more specific about lung collapse or overdistension, then of course you can see this percentage here will be much, much lower, because due to the fatty tissue around the lungs, there's no space for ventilation or for the lungs anymore. So in these kind of cases, we have to adjust manually the layer, the size of the layers, to adjust it for this smaller ventilated region. And that is, of course, in this concept, can be considered to be a limitation, because then the user has to manually adjust the regions of interest. And so we do not have this standard numbers anymore, where you could compare a dorsal or a dorsal lung, the ventilation of a dorsal lung of a slim and obese patient. Okay, then there are some other parameters that have been published that are meant to express the homogeneity of the lung, of the distribution of the ventilation. The one is called the Global Inhomogeneity Index, and that is also an index that basically calculates the standard deviation within the ventilated area. And it's called an inhomogeneity index. So it means when inhomogeneity is high, so the lung is very sick, then this parameter would show higher numbers. It has been described and also used in the literature, for example, to guide PEEP titration. And yeah, it's just a number. It's not, we do not get a dedicated image for the inhomogeneity index. It's just a number expressing the standard deviation. And then we also have another parameter that is called center of ventilation, which basically looks on the gravity vector within the ventilated lung. So it's also a mathematical expression to show if the ventilation distribution is well balanced between the ventral and the dorsal part. Okay, the second information apart talking about ventilation distribution is also that we can assess changes of the end expiratory lung volume. We cannot really express the absolute FRC, unfortunately, because we would have to have a calibration method to do that. And that is not available in most of the ventilators, so we don't have the information on the lung volume itself in milliliters, typically. But we can relate it somehow to the tidal volume, because the tidal volume is the only volume information on the lung that is actually available at the bedside. So we can then express the changes or maybe the increase of the end expiratory lung volume, which is always presented as an offset. We can express it as a factor of the tidal volume. So let's say when the increase is 1, that would mean if this was 500 milliliters, then this increase of the lung volume would be of equal quantity. For example, one way to use it has been also was described already in the literature is when you, for example, do a PEEP trial and you have a horizontal course of the end expiratory level, and then you go down with the PEEP, you can see that you will reach a PEEP level where step by step, breath by breath, the lung will be de-recruited a little bit, so you are getting a declining slope here. And that is already an indicator, especially if you compare it with a corresponding image where you see orange color is a loss of lung volume. Then you see when this lung volume is lost in the dorsal part of the lung, it is an indicator for de-recruitment. So meaning that the PEEP is obviously set to low. And that had been described in the literature by some researchers, but I would say it is not the most frequently used approach to titrate PEEP. Another approach, I already presented the first image here, that the absence of ventilation at lower PEEP levels is already an indicator of overdistension when it occurs in the ventral part. But there are also other techniques, and that is the one that has been described and published by Marcello's group in 2009 already. The first author was Costa, so we like to call it Costa approach. We could also say Amato approach, of course. And that is basically the interpretation of compliance changes or a loss of compliance. And it's when it happens at higher PEEP levels compared to the best compliance in a PEEP trial, then it's interpreted as overdistension. However, I should mention that this approach always requires a PEEP trial. You cannot do it during a steady state condition. And vice versa, you can also look for collapse. It can be assessed in the same approach. And so basically when we identify the best compliance for a pixel during a PEEP trial, and then we observe a loss of compliance during lower PEEP levels, then this is interpreted as collapse, as lung collapse. And this is a study that I mentioned from 2009. So, and it's for me, it's a little bit awkward to explain it, but maybe, Marcello, if I do something wrong on that, you can just slip in and provide more information. But basically, all it takes is to do a decremental PEEP trial, or could also be an incremental PEEP trial. And then we are calculating for each of the pixels, the pixel compliance. We identify the best compliance, and for each pixel, you will find this kind of course. However, in pixels from non-dependent lung regions, typically because there's not the effect of the gravity, you can set the PEEP, or the PEEP would be needed to keep the lung open or the best compliance at lower PEEP levels, while in the dependent parts, you should probably expect that the pixels require a higher PEEP for the best lung compliance. And as I mentioned before, basically the interpretation is just if the compliance drops towards higher PEEP levels, it's interpreted as hyperdistension, otherwise as collapse. Okay, so now we are coming to the cycling opening and closing. That might be a concept that might be new for most of you. And that has been also described and validated in the literature. I will show you the paper right afterwards. Basically, when we detect a time course of a pixel waveform, that is compared and always related to the average volume signal of the entire lung, which is a white line, and which could be considered to be the volume waveform. Then we see a late opening in the pixel and an early closing. Then we see that this is located next to collapsed lung region, basically the gray shape here. And we also detect a Peep dependency, so which means at higher PEEP levels, this area will remain ventilated and not showing this curse anymore. And with those 4 criteria, if they are present, then we can be quite sure this pattern is caused by cycling opening and closing. It cannot really be validated against CT scan during ongoing ventilation because basically the CT scan is too low. And you know, the CT scan is just a snapshot, so it cannot process such a dynamic process as cycling opening and closing. However, if you do this during a low inflation maneuver, then you could take a first CT during the end of inspiration or beginning of the slow inflation maneuver, a next one at the end of slow inflation maneuver, and then if you compute the changes between these two steps, then you basically, and that's exactly what they have done here, they found a good estimate of this parameter, regional ventilation delay, as compared to CT scan, computed CT scan, but it was not a single shot, but two. Okay, and then later on we found that this regional ventilation delay is also capable of identifying Pendeluft, for example. Because if we have spontaneously breathing patients, we typically see also large areas of ventilation delay in the ventral part. So not in this transition zone, but rather in the ventral part. These regions are also really large. And then in contrast to the peak inspiratory time here, which is identical timing between the average signal and the delayed signal. So here we have no delay at the top of end of inspiration. Here we actually see that we have also a delay during the entire ventilation cycle. And that is basically showing a waveform that is significantly delayed as compared to the average. And that has also been described one more time by the group of Marcelo. And so basically what we see here is a delay in the ventral waveforms also. And that can be also here, the subdivision was also done in the layers, as I just explained. And well, sorry, should I maybe wait? It's not me, sorry. That's quite funny. I wasn't expecting this kind of entertainment here. Yeah. No, I think that was just a little break. Now we are going on. Okay, so basically what you then see is a huge risk redistribution, especially during high respiratory efforts with extremely strong driving pressures, which are creating excessive pleural pressures just in the dorsal part. Then we basically see that the air is actually sucked from the dorsal part, no, from the ventral part towards the dorsal part at the beginning of inspiration. And just pay attention to this little detail. You actually see that at the beginning of the inspiration, it's not just a delay, it's actually that the yellow part loses volume because it even goes lower. You know, that is one of the criteria for Pendeluft, per definition. Marcelo.
Have you tried to quantify somehow using this?
But it's certainly a good idea. We should probably do a kind of cumulation. I mean, the only way we quantify is with this typical regional ventilation delay standard deviation. We also have a parameter which can basically relate the area that is affected, as compared to the entire area. So we can quantify the size of the affected area, and we can quantify the standard deviation that is also described in the original literature. But I know we should probably look how large is the amount which is actually extracted from the ventral part of the lung and then cumulated. That's certainly very valuable because that actually tells you then the extent of the volume that is redistributed, which is of course also considered to be harmful for the lung, without any doubt. Because then you are really getting, during this redistribution phase, you're getting extremely high local tidal volumes that can not be detected on the ventilator, of course. So basically, yeah, this information is also processed by computed tomography and, electrical impedance tomography. Next one, and there are also some studies, and I believe it's also, yeah, probably the first study was again from your group, so you can already see Marcelo is probably the most busiest individual on this world to do this kind of research. But there are other studies which have also kind of reconfirmed it. Sometimes they're using different approaches to do that, but we know no matter what kind of technology you're taking, you can process and display this kind of harmful information for about the lungs. Next one, detection of pleural effusion, and today I have actually given some internal trainings, and this information was also very new to the people, that you can, I would say, directly detect the presence of pleural effusion. And basically, I was cooperating closely with this research group from Kiel, which is just an hour away from my place. And when I told them my observations, then they said, well, it's very easy to do this kind of study. We have plenty of patients with pleural effusion. And so what they did is they have actually done a study. I should also mention, before I show the next slide with the study, we display the pleural effusion as purple spots in our images. So basically, when you have the normal ventilation signal, which of course is a majority here, you get a nice amplitude of the tidal volume, basically, or the volume waveform, I should say. The same is true for the ventilated pixel 1. But when you take a look on those purple spots, it's not a delay, it's not a phase shift, but it's really a phase opposition. So whenever you have a minimum in the ventilation waveform, then you have a maximum in the purple spot, and vice versa. So it's basically when flipping the curve along the x-axis. And so in this study, they have basically validated the presence of pleural effusion with ultrasound before and after drainage. And this is before drainage, large amount of those purple spots. After drainage, significantly lower, but still a remaining volume, and that I think is clear that a chest drainage never removes the fluid of the pleura completely. And the control group, they also had a control group, they didn't show these kind of effects. So basically they found that the sensitivity and the specificity of those purple spots is extremely high. And in order to really focus on that, you need to change the color scale. So it's very easy to just press a button, and then you're getting this purple spots displayed more prominently. And then this is right now giving a detection on the presence of pleural effusion. And Marcelo is absolutely right. We also, of course, should try to validate if this area here is really showing a linear relationship with the amount of pleural effusion. But we know already, and that has been demonstrated by this study, we know that the presence of those purple spots is well correlated with pleural effusion. And that basically the amount after drainage is significantly lower. So there must also be a relationship, of course, somehow regarding the amount of the fluid with the purple spots. Last but not least, and that is a little bit difficult thing to study, I believe, because we cannot just recruit patients into a study and then just wait until pneumothorax occurs. So that is a little bit difficult to do. You can do it, of course, in experimental trials, but not in reality at the bedside. But a detection of pneumothorax is typically presented like you have the absence of ventilation. And if the pneumothorax occurs during the measurement of ERT, you should also see, and that has been described one more time, also in this one study here, again by Marcelo. So basically you see that you get an increase of the end expiratory lung impedance. And in this time, of course, it's not really lung volume, but it's air volume inside the pleura. But it also can be presented. And then I also found when, I don't have many cases on that, but I also found that when you enhance the color scheme, basically these purple spots always occur in the when you have a sharp borderline between two regions in the chest with completely different impedance. It can be much higher, the impedance, like in the pneumothorax, or with a pleural effusion, it's much lower. And in both cases, you're getting these purple spots. So I think in the future, we can also take advantage of these kind of reconstruction artifacts, because that is what it actually is, in order to quantify and detect these kind of conditions. So to conclude, basically, I would say with electrical impedance tomography, we can easily detect the most common yet harmful lung conditions in our patients. And because it's non-invasive and can be applied continuously well, it's a perfect tool to be used at the bedside to monitor therapeutic interventions. Thank you very much. I think we will have questions at the end of this workshop. And now I would like to give Marcelo the word. I don't know if you have already uploaded the presentation. And please take the microphone.
Então, enquanto ele vai carregando lá, queria fazer só uma breve introdução. Então, eu agradeço aí o convite da Dräger, né? Sempre nós, ao longo aí de vários anos, a gente tem tido uma relação muito boa, porque de certa forma a gente, vamos dizer assim, formalmente somos como se fossem competidores, né? Mas na prática é uma coisa que eu acho muito interessante de pensar. Na verdade, a gente precisa ter um certo acordo de cooperação para a gente fazer a tecnologia desenvolver mais rápido, né? Isso está acontecendo muito com carros elétricos. Não sei se vocês viram, assim, os carros elétricos até foi uma iniciativa do Elon Musk, né? Ele subitamente ele falou assim: eu vou tirar todas as patentes que eu tenho para que essa tecnologia simplesmente floresça, porque meu objetivo é fazer com que rapidamente a gente pare de usar combustível fóssil, né? Então, de certa forma, eu tenho sempre sido grato aí, principalmente para o Eckhart, porque a gente tem tido um acordo de cooperação muito bom nesse sentido. Acho que faz bem para todo mundo. Então, e o disclaimer que eu tenho para fazer é que a gente tem uma empresa nacional, né, que faz uma outra impedância elétrica, mas é um fato aí conhecido. Então, eu queria mostrar para vocês aqui o que aconteceu durante a pandemia, porque nós tivemos uma sorte e um azar, né? O azar todo mundo compartilhou, acho que as pessoas até tiveram azares muito piores do que a gente teve. Nós ficamos numa UTI absolutamente lotada, com recursos ruins, mas a gente tinha umas 6 máquinas de impedância lá. A dificuldade era ter gente para colocar e ter tempo hábil de pensar em ciência, sabendo que a gente tinha que... todo mundo sabe o sufoco que foi, né? Então, eu vou mostrar aqui um protocolo que a gente teve que desenvolver rapidamente em 2 meses, e aí nós conseguimos randomizar 80 pacientes. Mas são 80 pacientes que foram tratados assim com uma estratégia que eu diria que é baseado na impedância elétrica. A gente tentou tirar o máximo de informação para randomizar esses pacientes. E aí vocês vão ver que todos os 80 pacientes eram monitorados com a impedância, mas só metade deles eram guiados pela impedância. No outro grupo, a gente fazia uma estratégia rigorosamente guiada por computador, mas obedecendo todo o algoritmo do ArdsNet. Tá? Gente, então, rápido, né? Sem perder tempo. Então, todo mundo ficou sabendo rapidamente que era uma doença trombótica, né? E principalmente no pulmão. E nos primeiros 2 meses da pandemia, a gente falando com os médicos, né, italianos e espanhóis, todo mundo falando: pelo amor de Deus, anticoagula esses doentes, que a minha UTI está lotada de TEP. Fui fazer anjo-CT, 40% dos doentes tinham TEP. Só que a gente viu cada vez mais dímero D estourado e não tinha TEP nenhum. E depois a gente aprendeu que era trombo local, trombo em todos os lugares do corpo, né, cérebro, rim. Depois a gente aprendeu também que o vidro fosco era infiltrado neutrofílico, que acendia muito no PET. Então, o pulmão do COVID é um pulmão com uma complacência boa, mas ele é extremamente pesado. Ele pesa mais que um pulmão de SARA, ele pesa 2 quilos. Em média, eu vou mostrar para vocês. O vidro fosco, então, é infiltrado neutrofílico, então você tem um septo cheio de neutrófilos e microtrombo em todo o interstício capilar. Aí no PET, o PET mostrou também uma coisa bem legal. Isso aqui, de novo, é inflamação. Você vê que coincide perfeitamente com o vidro fosco. Mas isso aqui é perfusão. Então, você vê que dá um match de inflamação e hiperperfusão de 60%. E é aí que vem a hipoxemia do COVID. Então, eu tenho um monte de perfusão justamente no vidro fosco, e o vidro fosco é cheio de pequenas atelectasias. Então, não é uma atelectasia aquela gravitacional, mas são pequenas atelectasias, tem um capilar hiperperfundido ao lado de mal perfundido. Com a impedância, a gente detectou algumas embolias, né? São casos assim que foi da água para o vinho a mudança de conduta. Nossa, cansamos de ver pneumothorax assim em tempo real. É uma pena que eu não pude documentar tudo. Cansamos de ver embolia como essa. E aí, olha, é interessante de ver, né? Então, o pulmão direito era super perfundido. Quem ventilava mais é o pulmão esquerdo. Então, com certeza, o que a gente tem que fazer no futuro é uma gradação como a gente faz no SPECT, né? Alta ventilação, baixa perfusão, aí a probabilidade de TEP fica altíssima. E é o que está mostrado aqui nessa área azul. Então, toda essa área aqui estava com alta ventilação e baixíssima perfusão. E aí você vê aqui, ó, é justamente onde está o trombo, tá vendo? E o outro lado que está telectasiado, ele está bem perfundido, né? Então, esse com certeza vai ser um sinal assim que vai dar para usar à beira do leito. Espero que cada vez mais. Então, esse é o... então, nesse trabalho italiano, olha que interessante, eles mostraram que tinha dois tipos de pulmão. Um pulmão que ele é hiperperfundido, que ele fica em vermelho, isso aqui é dual source CT, e um pulmão totalmente, vamos dizer, isquêmico, ele é azul. Os dois com a geografia normal. Então, é microinfarto, né? Microtrombo na circulação pulmonar. Então, é interessante de ver que isso explica muita coisa que a gente vê no COVID. E aí, o que eles viram? Os pacientes que eles têm uma combinação de muita má perfusão pulmonar e muita baixa complacência, é o paciente que morre mais. E aí a gente focou nesses pacientes. O critério de entrada no estudo só vai entrar no estudo o paciente com baixa complacência, porque eram os pacientes que estavam morrendo mais mesmo, né? E lógico que todo mundo era muito hipoxêmico, né? Então, queria só dividir uma coisa com vocês, né? Esse é o clássico, a clássica contribuição dos italianos. Eles mostraram que, na verdade, a complacência da SARA normal, clássica, e do COVID era um pouco diferente, né? A média do COVID é um pouquinho maior, mas você vê que tem um overlap gigante. E aquela história de ter dois fenótipos, na verdade, se mostrou falsa, né? Na verdade, a gente aprendeu que os dois fenótipos, na verdade, eram dois espectros e é uma espécie de evolução. Todo mundo aqui deve ter vivenciado um paciente que começou com uma complacência ótima, você pega ele dali a 3 semanas, ele já está com 15 de complacência, né? E você penando para extubar o doente. Então, aqui uma coisa que eu comentei com vocês, olha o peso. Ele é até maior no COVID do que na SARA tradicional. Tá? Então, o pulmão é pesado, mas a complacência realmente é um pouquinho maior. Isso é o que acontece, então, com quase todo mundo que lidou com esses pacientes, os pacientes difíceis, né? Eles entram aqui com uma complacência razoável e aí, ao longo das semanas, mesmo que você está fazendo uma estratégia protetora, ele vai perdendo complacência. Aí, nós fizemos a seguinte hipótese. Pô, por que ele perde tanta complacência? Por que a gente não... A gente está fazendo tudo o que pode para proteger o pulmão, por que o doente vai perdendo complacência? E aí, justamente porque a gente tinha impedância elétrica, a gente fez a seguinte hipótese, que a gente começou a ver algumas coisas. Ó, parte dessa perda de complacência não é fibrose, não. Isso é colapso. E é colapso que a gente começou a ver na CT desse jeito. Esse aqui é um paciente meu com 15 dias. É colapso gravidade dependente. Então, isso aqui é escolha errada de PIP. Não tem dúvida. Então, como é que a gente poderia escolher melhor a PIP? Isso é uma linha de pesquisa que a gente tinha estudado muito em 2018, porque a gente queria entender assim, quanto de PIP eu preciso para não deixar colapsar uma cirurgia abdominal comprida, ou uma cirurgia cardíaca. A gente sabia que o problema principal é a gravidade, então a hipótese é de que o COVID é uma anestesia longa, o cara vai ficar 3 semanas entubado. Então, eu teria que tratar como se fosse um paciente em anestesia por 3 semanas. Né? Então, a gente sabe que em anestesia, é um problema que agora ficou bem descrito com diversos estudos fisiológicos, né? A telectasia do decúbito. Então, nesse trabalho, a gente estudou essa telectasia. E o que a gente viu? Né? Esse trabalho, então, teve muita contribuição aí de várias pessoas aí da anestesia lá do HC. A gente viu que, quando usava o PIP da instituição, normal lá do HC, que era 4, volume corrente protetor. Os pacientes, quando você ia olhar na impedância elétrica, eles estavam... Tinha 50% do pulmão estava colapsado. Todos esses doentes eram meio gordinhos, por coincidência, porque era cirurgia de vesícula. Então, ficou muito parecido com o fenótipo do COVID. Né? COVID, você pega qualquer levantamento nacional, a média de Body Mass Index é 30. Eu estou falando longe? Ah, perfeito. Então, aí o que a gente viu? Que quando chegava no final da cirurgia, esse paciente era estubado e fazia uma tomo. E ainda estava cheio de colapso, olha aí. Olha o que tinha de colapso num cara estubado de uma cirurgia abdominal e recebeu toda a melhor estratégia lá que ele podia fazer. Tinha feito já uma sessão de fisioterapia. Aí a gente pegava um outro paciente similar, titulava a PIP com a impedância, era estubado com essa PIP da impedância, e aí no pós-operatório ele não tinha colapso. Né? E aí isso aqui é o resultado do estudo. Aqui é o crossing point, né? Aquele PIP onde eu tenho um cruzamento de colapso e hiperdistensão. E aqui eu estou vendo o Body Mass Index. Então, tem uma correlação muito boa, né? O paciente mais obeso é o paciente que mais precisa de PIP. Mas uma coisa que surpreende muito é o spreading, né? Olha isso aqui. Então, eu olho para o peso da pessoa, olho para a barriga, eu não consigo prever quanto de PIP ele precisa, né? Eu preciso medir. Então, isso aqui tem que ser individualizado. E aí, hoje em dia, a gente até entendeu um pouco melhor que essa necessidade de PIP depende assim do shape do tórax, da dimensão do tórax, é um monte de fator antropométrico, né? Que é difícil de você prever olhando ali à beira do leito. Então, a ideia precisa ser individualizado. E quando a gente faz isso, a gente mostrou não só que tinha menos atelectasia, mas eu preciso de menos oxigênio no pós-operatório. Tá? E nesse trabalho, a gente conseguiu diminuir o tempo de internação do paciente no hospital. Então, isso aqui é anestesia, tanto cardíaca quanto abdominal. A gente diminui o tempo de internação se você previne essa atelectasia de decúbito. Bom, associado a isso, vocês lembram que os primeiros trabalhos onde a gente mostrou a existência do Pendeluft, a gente mostrava também que o Pendeluft causava isso, né? Ele aumenta a inflamação no PET. Então, uma ventilação espontânea com 6 ml por quilo, quando é muito intensa e principalmente quando faz Pendeluft, inflama o pulmão. E aí a ideia é que, então, de algum jeito, a gente tem que evitar essa contração muito forte do diafragma. Então, uma das estratégias, por exemplo, que a gente usa para isso, que eu me surpreendi muito, porque foi a primeira vez que eu vi isso acontecendo, a gente sabe que todo doente reage pobremente ao oxigênio, em termos de drive ventilatório. Está vendo? É uma relação muito pobre. Mas quando eu fico hipoxêmico, aí o estímulo para o drive ventilatório é muito alto. O que acontece com o paciente do COVID? A curva dele é assim. Só que ele também reage ao oxigênio. Então, é interessante que, então, em vez de deixar a saturação em 90%, você deixar em 95%, eu vi vários pacientes que aí, de repente, ele acalma. E você, em vez de você ficar lá dando sedativo, você dá simplesmente um pouquinho mais de oxigênio. E, basicamente, a estratégia que a gente imaginou fazer era essa daqui, né? Então, vamos individualizar a PIP, para evitar telexia de decúbito, e evitar muita força do doente espontâneo. Tá. Então, muitas vezes, para diminuir a driving pressure, a gente ia diminuindo a pressão suporte até o paciente praticamente ficar em CPAP. Tá? E deixava ele praticamente em ventilação espontânea, só com a pressão muscular agindo, e uma PIP alta. O paciente ficava com uma PIP de 15, 16 em CPAP. Tá? Eu não vou descrever aqui os princípios do helmet, deixa eu só pular isso aqui. Mas depois a gente pode falar disso. Porque usamos helmet demais, tá? Porque o helmet foi uma excelente ferramenta para fazer isso. Você deixa o cara numa PIP de 15, mas em CPAP, né? Que acaba sendo bem mais protetor. E aí, então, a gente pegou esses doentes aqui do COVID, né? Que foram 80 pacientes. Então, primeira questão. Esse já é o resultado do Recruit. So, the first results of the Recruit part. Então, nos primeiros pacientes, a gente só queria saber, esses pacientes têm mesmo colapso? Eles são recrutáveis, né? Porque muita gente começou a falar que paciente com COVID não é recrutável. Então, está aqui a resposta, né? Olha só quanto de colapso eles tinham e como eles responderam ao recrutamento. Então, assim, super recrutáveis. A maioria dos doentes tinha muito colapso junto. No entanto, tinha uma complacência muito boa. Então, esse ficou o desenho do estudo. Então, a gente incluiu 93 pacientes no protocolo Recruit, que era só para saber, esse doente é recrutável ou não é. E depois conseguimos randomizar agora 80 pacientes. Aí uma estratégia era guiada pela impedância, a outra era a gente guiava pelo computador, mas segundo a estratégia ARDSNet. Então, na impedância, a gente escolhia a PIP aqui, né, no ponto de cruzamento entre colapso e impedância. Esse é um paciente com COVID. Você vê que esse era um paciente obeso. Um pouco confirma o que o Eckhart falou aqui. O paciente obeso, ele fica com uma imagem pequenininha, né, centralizada. E olha, vamos dizer, o cruzamento do colapso com a hiperdistensão é numa PIP de 18. E a gente escolheu exatamente essa PIP para os doentes. Isso aqui, eu acho esse slide sensacional, porque olha o que ele está dizendo. Todos os doentes, eles eram submetidos às duas estratégias em questão de 2 horas, para a gente entender como é que eles funcionavam. Depois ele era randomizado. Tá? Então, quando a gente testava a tabela do ARDSNet, essa aqui era a PIP resultante. E aí o doente fazia a impedância elétrica e aí a gente escolhia a PIP ideal. Então, vocês vejam que não é estratégia PIP alta ou PIP baixa. É PIP individualizada. Alguns doentes têm que subir vários centímetros de água e outros doentes eu tenho que diminuir vários centímetros de água, porque eles estavam hiperdistendidos quando submetidos à estratégia do ARDSNet. Uma coisa interessante é que aqui é o PIP escolhido pela impedância elétrica, né? Então, claramente, também confirmando o estudo anterior, os pacientes obesos precisam de muito mais PIP. Aqui é a driving pressure de entrada. Tá? Então, ambos os braços tinham uma driving pressure perto de 14, 15. Aí o paciente é randomizado e aí ele começa a usar a PEEP titulada pela AIT. Então, na primeira hora, a gente já vê essa diferença e em 24 horas a gente observa o quê? Que a driving pressure aqui caiu para 11 e a driving pressure aqui continua em 15, na estratégia ARDSNet. Os pacientes melhoram de oxigenação, mas não é dramático. Então, o resultado de oxigenação não foi brilhante, não. A PF de 100 ia para 160, 180. Tá? Mas isso não era nosso objetivo. O objetivo era realmente proteger. Aí, olha que interessante. Pela primeira vez, a mudança da PF não se correlacionou com o colapso. Ela se correlacionou com a hiperdistensão. Então, isso é diferente no paciente com COVID. Os pacientes com SARA, normalmente, você tem uma correlação muito alta entre mudança de colapso e mudança de oxigenação. No paciente com COVID, não. Provavelmente por conta dessa trombose microvascular. Então, esses pacientes são muito sensíveis à hiperdistensão. Então, se você hiperdistende o doente, você piora a oxigenação. Também vimos que prona e supina é sempre uma surpresa. O mesmo paciente em supino precisava de uma PEEP de 14. Em prono, 20. E vice-versa. Tinha paciente que era o contrário. E tinha paciente que ficava extremamente hiperdistendido em prona. Principalmente com a estratégia muito comum agora, que todo mundo prona e faz um trem de Allenburg reverso, né, para poder alimentar o doente. Nessa posição, a hiperdistensão é violentíssima. Assim, geralmente, a gente tinha que baixar uns 6 centímetros de água de PEEP. Tá? Então, é interessante. E vi muito doente que o pessoal falava assim, não deu certo em prona, porque a complacência ficou muito pior. Ficou pior porque hiperdistendeu. Tá? Então, era muito comum aí a gente ter que baixar a PEEP por conta da posição prona. Bom, a gente usou também muito um truque que desencadeado pela observação na impedância elétrica, né? Então, você está vendo aqui o paciente em posição supina, bastante colapso dorsal. Aí você vira ele em posição prona. É interessante que isso aqui você consegue monitorar com a impedância. Aí você vê que lentamente ele vai começando a ventilar as costas e vai colapsando na frente. 100% dos doentes, 100%. Aí, como a gente já tinha titulado a PEEP aqui, eu já sabia aqui, ó, ele precisa de uma PEEP de 12. Aí, o que a gente fazia? Antes de supinar, eu subia uns 4 pontos a PEEP. E aí, quando a gente supinava o paciente de novo, ele ficava muito melhor. Então, olha só um exemplo prático disso. Esse doente, mesmo depois de recrutamento, tudo, ainda tinha 39% de ventilação dorsal. Aí fizemos todo esse ciclo em prona, sem precisar recrutar, e aí ele fica agora com 56% dorsal. Vocês viram que a mudança de imagem a mudança de imagem é bem expressiva, né? Ele começa a ter muito mais ventilação dorsal. Outra observação, né, é o que eu estava falando para vocês. Olha o que ele tem de hiperdistensão em prona e em supina, mesma PEEP. Então, muitos pacientes tinham muita hiperdistensão em prona, então a gente precisava baixar essa PEEP. Tá. Então, slides finais. Então, isso aqui é a taxa de número de pacientes, né? A pandemia foi muito forte aqui, então a gente incluía 5 pacientes por mês, mas agora nos últimos meses a gente não consegue incluir mais do que 2 por mês. Então, provavelmente nós vamos ter que terminar esse protocolo antes de conseguir o N final. Então, eu vou mostrar alguns resultados que a gente observou, então, nessa amostra de 80 pacientes. Então, essa aqui é a PIP na entrada, 12, em média, escolhido pela estratégia ARDSNet. Aí randomizava, a média aqui ficou 14, a média aqui continuou em 12. A gente já conversou sobre isso, né? Então, não significa que todo mundo subiu a PIP, alguns subiram, outros desceram. E essa foi a evolução nos dias, olha, 0 a 30. Então, aqui a gente segurava a PIP e estubava o doente numa PIP em CPAP de 15 ou 16, tá? A PIP que ele... Porque a gente titulava vários dias seguidos e o doente continuava precisando ainda de uma PIP alta. Quem precisava de uma PIP alta na entrada, ia assim até o final, quem era baixa, ia baixa até a final. Então, não vai mudando muito. Então o doente ficava mais ou menos com a mesma PIP, enquanto no ARDSNet ele vai caindo. Volume corrente foi similar, nos dois braços, ao redor de 6. Mas aqui entrou já um efeito que me deixou muito feliz. Olha a diferença de complacência. Então, ela apareceu no primeiro dia e foi até o final. Tá? Então, a gente conseguiu uma grande diferença de complacência entre os dois braços que não se perdeu. Então, mostrando que tem algum benefício que persistiu. A driving pressure também. A driving pressure ficou aqui sempre 4 centímetros de água mais baixa nessa estratégia. A gente observava uma melhora no raio-x. O raio-x era observado todo dia aí por um observador neutro. E tinha uma melhora no raio-x. Não era assim muito evidente, mas tinha. E mortalidade foi a mesma nos dois grupos, porque... e foi baixa nos dois braços, ainda bem, porque nem era o objetivo do nosso estudo, porque a gente não estava fazendo um estudo de mortalidade. Nosso objetivo era mostrar que a função pulmonar melhorava mais rápido nesses pacientes. E isso foi verdade. Olha só que interessante esse slide final aqui. Isso aqui é uma métrica que a gente tinha pensado desde o início, que a gente queria observar quanto tempo o paciente consegue... Basicamente isso aqui, qual é o tempo que o paciente demora para sair do hospital? Porque vocês devem ter vivenciado isso. A maioria dos doentes com Covid, depois que ele teve uma SARA grave, ele fica quase que um mês de enfermaria, até conseguir se ver livre do oxigênio, né? Então, como o objetivo aqui era melhorar a função pulmonar, porque a gente está diminuindo a driving pressure, então ele vai ter menos fibrose, menos consolidação pulmonar. A gente queria ver quanto tempo ele demora para sair do hospital. E aí a gente vê que então, quanto tempo ele consegue respirar, ter uma saturação de 90% sem oxigênio. Tá? E aí dá uma diferença de 8 dias, né, entre um braço e outro. Então, esse aí é o resultado final. Na prática, todo mundo sabe que, mesmo com essa diferença de 8 dias, ainda é um desafio tremendo que acontece com esses doentes, né? Eles ficam com várias sequelas motoras, porque precisaram ficar paralisados aí muito tempo. Então, acho que é uma doença ainda que precisa de muita coisa para melhorar, né? Mas eu achei interessante que fazia tempo que a gente não conseguia mostrar uma melhora da função pulmonar efetiva com alguma estratégia ventilatória, né? Porque eu acho que os últimos trials de ventilação mecânica foram bastante decepcionantes, né? Então, aqui, nosso objetivo não era mesmo mostrar a mortalidade, porque a gente sabia que não teria poder, né, de estudo para isso, mas pelo menos a gente consegue mostrar a recuperação mais rápida do pulmão. Agora, a gente está seguindo esses pacientes para saber se, como a gente usou mais curare nesses doentes, tá? Por incrível que pareça, Para poder aplicar esses princípios aí que eu mostrei, né, e titular com EIT, a gente acabou usando um pouco mais de curare nesses doentes. Mas mesmo assim ele sai mais rápido do ventilador e do hospital e do uso de oxigênio. Mas a gente está analisando agora as sequelas motoras, né? Então está tendo um segmento com o grupo da físio lá que está reavaliando isso aí. Então tá bom. Muito obrigado.
Acho que agora os dois juntos, né? Bom, a gente só vai fazer uns ajustes para que tanto o Eco quanto o Marcelo Amato façam essa parte da apresentação. Daniel, você conduz? Tá. Enquanto isso, acho que só para ganhar um pouquinho de tempo, né, desviar um pouquinho a atenção desses ajustes, mas acho que fica nítido o quanto a impedância pode ajudar no momento de atuar com pacientes tão complexos e com uma doença tão desconhecida. E foi com esse raciocínio que a gente construiu a agenda. Então, falar um pouco das ferramentas disponíveis na toma de impedância, mostrar na prática toda a experiência que o Dr. Marcelo e o grupo dele no HC conseguiram extrair e transformar em dados. E agora a ideia é que a gente faça uma mistura das duas apresentações para que torne isso ainda mais palpável para quem está na prática clínica utilizando uma ferramenta como essa, né? Então, teremos os dois palestrantes juntos. Echo, can you come for the next part, please?
Okay, so Marcel and I did not talk about all the details, how to go on with that. I would like to work through together with you how to really use electrical impedance tomography in practical cases in clinical routine. We already have seen lots of publications and also results of study, but of course the thing how you actually use it more practically, and that is something where at least I have very many datas. I forgot to mention in the beginning, I'm not a medical doctor, so I'm rather an engineer, but I think Mariana has explained that to you. But at least I still have the opportunity to be involved in many, many clinical research trials, so I'm getting tons of clinical data. I'm always, of course, just getting the ERT data, so my limitation is always that I'm not getting all the surrounding clinical information. Many times I'm not getting chest X-rays or CT scans or do not know details about the patient condition. But I still would like to work with you through how, and that is more as also thought as a proposal, and you can, of course, add something or maybe say, Echo, maybe it should be done slightly differently. But then we can do it because this is a kind of workshop style, we can maybe just present some cases. I collected some interesting cases.
Nice.
And then we can
Very
basically first start with assessing lung recruitability. Because, and that is again a study where Marcelo was deeply involved in, I think we had some learnings from the ART trial, because in this ART trial that you all probably might know, we basically, or Marcelo's group has basically compared PEEP titration according to the best respiratory system compliance against the low PEEP table of the ARDS network table, right? And so this is basically the study protocol that has been done. However, the outcome was that the study group presented a higher mortality. And so there was some letter to the editors, and also I think it was an editorial, a letter to the editor, where basically Alexandre Cavalcanti, who I don't know personally, and you, Marcelo, you have basically observed that the harm which led to the higher mortality in the study group was concentrated in those which were basically not recruitable. And that was about at the time when we introduced, in Pulmovista at least, many years later that you did that, we introduced this Costa method with finding the best PEEP. And then initially when I heard about this study results, I thought, wow, is that now the end for recruitment maneuvers and subsequent PEEP trials? But I think the very important learning from this trial is that we have to assess lung recruitability before we consider active, aggressive recruitment maneuvers. And so I would just, I have many data, so I just was looking for some tests where the PEEP was just elevated slightly for a very short period of time. And I would like to give you examples how you actually can do a very minor, moderate test in order to test lung recruitability. So that is the first case. So, and that is, I just explained shortly how I would assess these kind of data first, and maybe then Marcelo, you can also give some recommendations. So when we find these kind of patients, and that is actually in intensive care patients with a compromised gas exchange. However, when I look on these data, I see immediately, that is my interpretation, there's not very much wrong with the ventilation distribution. It looks like almost the same like a healthy volunteer. And you also see that there's a lot of ventral distribution, 9%. There's also a lot of dorsal distribution. And then I would already be hesitating if I would include such a patient into a recruitment maneuver. Okay? Then the next thing I would do is checking for the presence of Pleura Fusion, and there I would be looking for the purple spots. In order to do that, I have to press this button below the title image. And if you see this, I see in the dorsal ventilation, in the region number 4, there's not any spot, not any presence of Pleura Fusion. So that already reconfirms me. So here, lung recruitability cannot be compromised because there's a significant amount of Pleura Fusion. I'm not sure, Marcelo, do you have any explanation for this purple spot that is right in the center there?
No, in fact, I don't.
Press the button, then explain the screen.
No.
I would expect this purple dot in pneumothorax, as you showed, because really there is opposition of phase.
Yes.
Really there is opposition of phase. But for pleural effusion to have opposition of phase, for me, it's maybe, I think maybe this means that when you get the inspiration, this region accumulates more fluid because it was like a kind of, it was distributed along the dorsal region, but then once you pressurize the thorax, it went down close to the diaphragm. And then you see a spot of the impedance going down because of this liquid. But this would be one explanation. The other one is that is just an artifact.
Yep.
I'm not quite sure. So
Okay.
I have seen that in spontaneously breathing patients with very large pleural effusions, I have seen this opposition of phase, and it was confirmed by ultrasound.
Yes.
So it was real.
Yeah.
It was real because when the patient was, because the patient had an eversion of the diaphragm, so the concavity was the other way around.
Okay.
Because of the big pleural effusion.
Yeah.
So maybe also this, let's say, concavity, the reverse concavity of the diaphragm is causing this.
Yeah. Okay.
But anyway, I noticed.
So this is probably something, a new research field where we have maybe to put more thoughts,
attention.
More attention to. Definitely, I think it has been validated precisely with a study that the purple spots are closely related to pleural effusion. Now it might be the explanation, is it rather a physiological effect? And it's actually quite complicated because it's a function of time and also of space, because everything is moving in this part, right? So it's quite a complex setup where you really need to think about, how impedance changes over the time, but also, the pleural effusion, as you pointed out, the borderline is changing in the course of the ventilation, of course.
But it's a good study to do together with CT. And
Yes.
I think it will give us some insights.
Yeah.
Nice.
Yeah. So my explanation actually for this purple spot in the central could also be that we tend to see this in the presence of fluid. And I think this is rather also the position where the aorta is located. So it could also be basically displayed by the big vessels which are close to the vertebra.
Okay.
But that is speculation. We don't know yet. However, with our device, we basically validate that we have an absence of Pleura Fusion because we don't see any purple spots. Okay, so now we have to load the data, sorry, because I want to show the time course, how the reaction when you do this kind of maneuver, just elevation of PEEP. And therefore I have to load some more data. So that series now represents, let's say, an observation period of 17 minutes. And all that has been done for this patient is that basically the PEEP had been elevated for about, in this case, about 8, in order to test how does the lung react when you simply elevating the PEEP. Now it takes some time to load up the data. Okay, and then I would like to introduce the so-called Diagnostic View. And there you basically see the maneuver that has been performed, and it's a very simple one, obviously. I have to extend the time. And in this view, then you basically set one baseline point before the maneuver has been done, one in the middle of the maneuver, and the third one afterwards. 1, 2, 3. Also want to extend the, and now we check basically recruitability. And Marcelo, we already talked about that for a long time. I think there are 2 aspects of lung recruitability. The one is changes in the lung volume, and the second one is changes in the lung compliance. And what we both, I think, observed, we've talked about that, is that they're not always directly related to each other. So it seems to be 2 sources of independent information.
Absolutely.
Right?
And the very reason for this took me some time to understand why they could be so, there could be so much dissociation.
Yeah.
I think one of the best is, and then we did a study together with CT, and what we observed is the following. Sometimes, let's suppose that you have a completely collapsed lung zone, but once you challenge, like in this position here, you have a big gain in volume, but this region suddenly is already pop open and already overdistended. So, which means that you can gain an immense amount of volume because the pop open is a big jumping volume, and now you're jumping from an alveoli that was completely collapsed and then is completely overdistended. So the gain in volume is huge, but the compliance is not much because now I'm already overdistended.
Ah, okay.
So this is why sometimes you gain a lot of volume but not much compliance, and vice versa.
Okay.
And to prove that this is true, this is the region where you have the highest gain in volume, and this is the region where you have the highest gain in compliance, typically. I don't know what you did find here.
Yeah, basically, there was a gain of compliance, which is shown here by this. So basically, we take the baseline condition, A, as a reference, so no change against the reference, of course.
Okay.
And then we basically display what happens when you slightly
is
increase the volume.
compliance.
That is compliance.
Oh, okay.
And that is, the blue is compliance win,
Okay.
and this one is compliance loss.
Yeah, so this is very dorsal. And this is gain in volume?
That is a expiratory lung volume that is gained.
You see, it's global.
Yeah, it's global.
And this is always dorsal.
And this, of course, and that is something that I also like to change. Right now, of course, we have this artifact because just by increasing the PEEP, we increase the force that keeps more air inside the lung. And so automatically, we would have to subtract this.
Yeah.
And that is what we intend to do.
Perfect.
So right now, in this current version, we always see, but the extent of increase due to the PEEP is also very different from one patient to the other. What we actually directly can compare is, in this patient, we won some lung volume. However, if you see the course here, this effect fades away over time, basically because it's a slow reshaping of the diaphragm over time. So the effect will be gone after a while, I'm pretty sure. But when we see this kind of effect, of course, we have a slight redistribution of the compliance. However, if you compare these images here with each other, I don't think we see any beneficial effect. So, and the explanation for me in this case is that the patient lung was fully opened even at the baseline. I don't know.
Yeah. Is this the same PEEP level?
Yes. The PEEP level is actually given here by these numbers here. So A5, C5 means PEEP level 5, and that was actually in this case a relatively large increase of PEEP already.
Yeah. I think I agree, but maybe there was some gain in compliance, remaining gain. So there was some hysteresis, right? And some hysteresis also in volume.
Exactly.
And then I think what you have to check is that, is this gain in compliance enough to decrease your driving pressure substantially?
Yeah.
I think this is the goal. And looks like that in this case is not much.
It's not much, and the effect, if you set more analysis point, this effect is actually fading away over time, as I can demonstrate you here. So if I just set some more points, analysis point, sorry. So basically you see that, and then you redo the analysis, you will see that both the win of lung volume and the win of compliance will fade away over time. At least you see that it's getting significantly less.
Yes,
yeah? Both for the lung volume and the compliance. Yeah. So to me, my interpretation is this is a non-recruiter. And if the dorsal ventilation is already 10%, typically this is a value of lung healthy individuals. So there's not a lot of gain to be expected. Okay. That was the first case. The second case I'd like to show you. The second case is a little bit more complicated. So this is a case, and we don't show it here in this specific view, but there was a presence of those purple spots related to Pleura Fusion, and you can indirectly see where the Pleura Fusion is located. And also there's a presence of pendeluft in this patient. You will see the end expiratory pattern is very unstable, so that was a spontaneously breathing patient that's having a completely different course of the end expiratory lines, typically. And now, basically, you can see this is not mandatory ventilation because typically the end expiratory level is really like a straight line if you don't change anything on the patient and with the ventilator settings. So I just set the cursors as I did before. Now I'm using this one. And here you see the PEEP was just minorly increased of 4 centimeters of water. And let's take a look on this patient now. So I think everybody of you will immediately realize there's something wrong with the dorsal ventilation, obviously. When we just do this little increase of PEEP by 4 centimeters of water, we basically only lose compliance here. That is a compliance loss. that already occurs at 4 centimeters of water. Now, can you imagine you would have included this patient into the art trial? That was exactly the problem. But in this art trial, ERT has not been used yet. And the only little win that you see here, the 3%, it's just basically at the borderline where the pleural perfusion is. So right now in this image, you only see at the location where there's pleural fusion. Of course, there can't be ventilation. Right?
Excellent point.
Yeah.
This was very good. And this patient was under a spontaneous ventilation, or?
Yeah, he was definitely breathing spontaneously. I don't know. I don't have all the data of that, and I don't have the information on the ventilation mode that was used. However, just this unstable, very uneven line here suggests that was.
I'm just asking this because typically spontaneous ventilation typically is another, let's say, force that tends to put ventilation more dorsal. So if this patient, even with spontaneous ventilation, doesn't have any dorsal ventilation, is because the amount of collapse is huge, or he has some condensation here that cannot be opened. But certainly with this result, I would not use higher peak.
Yes, exactly.
Yeah.
So, and well, with the help of the purple spots, we can detect that there was actually fluid. The only thing I'm not sure about is yet right now is it only related to pleural fusion, the purple spots, or is it possible that also lung consolidation will lead to the purple spots? That's what I do not know. So if you have any chance to for example, compare a patient population with verified pleural fusion against lung consolidation, that would be very interesting to have a talk about, or maybe to do a study together even. Yeah. Okay, so again, this is definitely a typical example of a non-responder, because if you slightly increase the PEEP, and I know there's a theory from Burkhard Lachmann, I know we both know Burkhard very well for a long time. He always said, open the lung and keep the lung open. But he was basically making this concept based on his animal trials. And if you do lung lavage in the animal trials, of course, you always can easily open it. And then he is definitely right. But I think for these kind of patients, I would really doubt that this concept would apply to such a patient. You cannot always use it. And I just for this patient would like to show you quickly the Pleura Fusion. And therefore I have to start the online mode. Because right now this is the only view where we can actually change the color scales. And if you do that, and as said, currently I'm very confident that this is always referring or displaying Pleura Fusion. So you basically see these purple spots bilateral in the dorsal part. And as I said, the study has validated that this is representing Pleura Fusion. Even though we might not be absolutely clear about the origin.
Rickard, what precisely this button is doing? So it's just enhancing the contrast between this dynamic image?
Yeah, it's just, you already see here slightly this purple spot, even in the normal color scaling.
So okay, so it's out of phase.
And basically, right now, let this end values of the scale be maybe 20%. And if we send the end scale to 2%, or the factor 2, then we are just increasing the colors.
Okay.
That's all we do. So it's basically just a very simple thing to do, and then you see this opposed signals. Okay. If you allow your system to actually display the negative
ones.
Yeah, the negatives. Yes.
Yes.
Exactly. That's what we also. Basically, that's what we do with the normal color scaling as well. Yeah. Because we want to focus on the ventilation distribution. And I also thought until maybe 8 years ago, 5 years ago, that this is basically mainly related to noise. It's related to an artifact. I still believe it's an artifact, but we should investigate on that in more details.
For sure.
Yeah. Now I've shown you two examples of non-recruiters. One because the lung was fully open, the next one because there was a presence of Pleura Fusion. And of course, I would also like you to show you a case, an example where recruitment probably works. And that is a last case that I would like to represent. Again, I have to load a little series of data. And I believe what we see right now is, I believe that is a kind of a typical pattern of a post-operative patient. Because typically, I don't know about your experience, but in my data, I often see lung collapse that can be recruited in post-operative cardiac surgery patients.
Yeah.
Same to you?
Absolutely. So and they are typically a little bit obese.
Yes, there's also, as you pointed out, there seems to be, even though it's a large variation, but there seems to be a trend and information on that. Yeah. Okay. I still have to get used to my glasses. Especially when I'm wearing a mask and I only have fog in front of my eyes. That doesn't help at all. Okay. Okay, Marcelo, what do you think?
Yeah. Very little dorsal ventilation. So I see some spots of ventilator delay index.
Yep.
And in this case, there is much more blue than orange. And then, okay, I have lost something here, but maybe this patient, by looking this image, looks like that the compliance is a little bit better there, which means that we have very likely lower driving pressure. So I would, there is some good signal here. Maybe I would challenge a little bit more.
Exactly. I completely agree. I think this is exactly the ventilation distribution which calls for a recruitment maneuver and a PEEP trial afterwards. This is exactly, and that is for all the post-operative patients, as you pointed out already with the surgery and this 3-week, how did it call it? Atelectasis decubitus?
Yes.
Something?
Yes.
I heard the term the first time, but I really like it very much. And we don't display here these percentages, but the ventral lung, as you can see, is much brighter. It had 80% of the ventilation. Only 20% was delivered here. If you just increase slightly the PEEP by 5 centimeters of water, you already see a large increase, because basically this percentage says that there's an increase of compliance in the dorsal region where there was little ventilation, and you only have 6% loss in this particular ventral part of the right lung, which means in total you have a win of compliance as compared to the baseline of 17%, which is for such a small increment of the PEEP quite a lot. So this patient, I think, calls really for a higher maneuver, a recruitment maneuver, and a PEEP trial.
Yeah. And also, I like to see that you have lost most of it here, which means that this is clearly insufficient, right?
Yes.
Because you gain here and you lost, and then you could make use of a little bit better PEEP.
Exactly.
So this patient requires titration.
Yes, right.
Yeah.
Okay, so talking about titration, maybe this is the last case, and then we should start a discussion with the group. The last case I would like to show you, and we already discussed this case because it's very interesting. It's one of my favorite cases, is a PEEP trial for those patients where you find these kind of patterns. And unfortunately, we do not have much more time because I have plenty of those interesting, very interesting PEEP trials. So again, this was a post-operative cardiac surgery patient. Surgery lasted for about 4 to 5 hours. And I think it was a cabbage intervention. And basically, we have the same concept with this estimation of overdistension and collapse, where you always find this crossing line. And I can tell you, I've probably reviewed more than 100, 200 PEEP trials. When the PEEP trial has been performed properly, you always see this kind of pattern. If there's something wrong and you find like 2 crossing points, there must be really something wrong with the patient or with the maneuver.
Fully agree. Yeah. It's a very consistent finding.
Yeah. And that also makes operation and clinical practice, of course, easier because basically now you have kind of an orientation point where you really can aim for. So basically, and that approach is also very user independent because this analysis point for each of the PEEP levels can be identified with a high reproducibility. The crossing point is here. So between a PEEP level of 8 and 10, what kind of PEEP level are you typically using in such a patient? Rather the next higher one? Or would you do a fine titration with steps of 1? What is your approach, Marcelo?
How many PEEP steps we
5.
have here? 5 PEEP steps. Yes, sometimes I try to make it a fine tune, but if I see that there is very little noise, and this case looks like that there is very little noise, I see from the plethysmogram, the PEEP also estimation looks like everything has little noise. So I think it doesn't make much difference if I try to make 1 by 1 centimeter of water. Mm-hmm. And then as I was telling Eckhart that we have a fellow that is now in Toronto, and he's testing this approach, which gives you minimum overdistension, this PEEP level, which gives you 0 collapse, or the crossing point, or the closest possible to the crossing point. And then what he found is that this is not stable. This is a PEEP level that typically gives you more collapse along the time. So in about 1 or 3 hours or 6 hours, you are going to be in trouble.
You mean when you try to completely avoid overdistension?
Exactly. Yep. So for some reason, the lung, and makes sense because, you know, typically when we are sitting or we are breathing here in room air, we have a little bit of overdistension. So we are made in this way that we always have a little bit of overdistension. So if you try to keep it at this point, you are going to be in trouble very soon because of atelectasis. Yeah. And then the crossing point and this one, in terms of macroscopic findings, they were the same, but the hemodynamic system is the worst here. Yeah. Because you're applying too much PEEP and you're creating a little bit of overload to the right ventricle. So looks like that typically we prefer these crossing points. So I would choose this crossing point.
And I mean, just reconfirming what Marcelo said, I mean, if you try to minimize overdistension and you look at the corresponding image here, you see already that there is a massive collapse at this PEEP level. The question that I always have is, I mean, we always talk about overdistension, but is it really clearly defined when you just look on the drop of compliance to which extent a lung may be overdistended without doing any harm, or do we have a clear definition for overdistension that is harmful?
No, I think we don't. But we can. This is why I like to relate in terms of driving pressure. So, how much more driving pressure this overdistension is creating for us? We don't have yet a good index to talk about this, but I would always think about something like this. So, how much excess of driving pressure this overdistension is creating for us? Because at least we have a almost linear relationship between driving pressure and ventilator-induced lung injury, or driving pressure and mortality. But we don't have it for overdistension. So it's very difficult
But
to...
then, on the other hand, driving pressure is a global parameter, and so it's very challenging to relate it to this regional information then, right?
Yes, yes.
So I was thinking about, right now in our color scheme, everything that is gray means it is less than 10% from the maximum, and I think you probably do it exactly in the same way.
Yes.
So I don't know if, I would definitely say the absence, the absolute absence of any kind of ventilation, which can be ventilated. So when you see gray zones, like you see it here for the dorsal part, if you have no ventilation, then it means the lung tissue must already been so much overinflated that you do not have any chance to induce a major amount of air. And that also means automatically, then if you have no ventilation anymore, probably also the capillaries around the alveoli are already significantly suppressed. And that is, of course, something that you then hopefully can one day demonstrate, or you can demonstrate it with a perfusion signals.
Yeah, this is a interesting idea. I like
so
it.
when you have these two criteria, I think at least for those two criteria, no perfusion anymore in the ventral part, and the absence, the total absence of ventilation, my hypothesis would be that must be harmful overdistension, at least. But maybe the thresholds might be a little bit higher. That's what I don't know.
Good point. So yeah, this is a very interesting field. I think we are just starting because we didn't have tools to do this.
Yes, exactly.
And this is why Laurent Brochard was very happy to do this for the first time experimentally, because the problem is that all these studies about villi, they are very hard to apply at the bedside because
Yes.
we have different tools. And then
Right.
using these experimentally would be very nice.
Yeah. The only exception, I normally would also agree that probably PEEP level of 10 represents the best compromise between overdistension and collapse. What is, do you have kind of any threshold where you would say, I accept a certain amount of lung collapse in order not to apply too high pressures?
Yeah, every time we go beyond 5%, we typically progress to something that doesn't work well. Yeah,
That's
yeah.
matching exactly with what I found in the data. Yeah, very good.
Yeah.
So in this case, the particular thing about this case is that even though this might be the best compromise between overdistension and collapse, we can take a look here on this yellow waveform. And if you remember, that was cycling opening and closing. So when we are touching on this image here, basically we see this classical pattern that I defined with the 4 criteria. The one criteria is this pixel. So the yellow waveform is a pixel waveform that is located directly next to collapsed lung tissue. That's the first criteria. The second criteria is we have a PEEP dependency, which means when you increase the PEEP, you do not have the opening pressures below the PEEP anymore. So with the next higher PEEP, this is gone and is reduced to 0. The third criteria is a late opening. That is actually what this parameter is looking at. But in very many cases, however, not always, we also see this early closing.
Yeah.
So this is, for me, the criteria.
Yeah. To give us a little bit of intuition to go a little bit above this.
Yes.
Right?
Yeah,
Yeah.
I mean, if the price to pay, and of course we always have to carefully monitor the airway, the blood pressures for that, especially in cardiac surgery patients. But if the patient would tolerate a higher PEEP, just 2 centimeters higher, but it might already be impairing the circulation, then at least one could consider applying a higher PEEP for this particular patient.
Absolutely.
All right, so I believe we have about 10 minutes left, and we would like to also involve you very much in maybe some questions, some discussions. Maybe some of you have already worked with the ERT devices and have some questions. I don't know. Now I think we are done with the presenting material, and now it's time for questions and discussions. Yes.
Boa noite. Primeiramente, gostaria de agradecer, professor Marcelo, muito obrigado, né? Eco também, muito obrigado, Mari, por essa noite, né? A gente aprendeu bastante. Eu me sinto privilegiado em ver, desde a época que eu era residente, que a impedância ela era bem mais, digamos assim, caseira, né? Agora, algo desse nível já profissional. E uma pergunta que eu tenho é sobre a perfusão. Próximo software já teremos perfusão ou ainda não? Ainda falta um pouco aí. Obrigado.
Do you want to start?
Yeah, I mean, I can tell openly about our experience. So, of course, like Marcelo does, we also look very deeply into ERT perfusion. I was very disappointed, and I'm sure you were also very disappointed that the dream that we could have ERT perfusion in a non-invasive way continuously monitored is probably not possible. And it took me a very long time to accept that. Because, I mean, that would be the dream, that we have a PEEP trial and we basically can, like we do it with the ventilation, also monitor the ventilation perfusion match. That would be a dream, but unfortunately, that doesn't seem to be true. And it took me a long time to understand why, but it's not possible. I have to accept that. So, right now, we have done validation studies with our software. So we have a PC software that can calculate and display ventilation perfusion matching, and we already had the first publications on that in the last year, which really got large attention because it was also during the COVID time. So of course it would be great to have this kind of information, especially for those L-type patients, if we believe in phenotyping of COVID patients at all.
Yeah.
Right. And well, right now the situation is that we like to go on with the PC software, because we realize that it takes some more optimization loops in order to make this algorithms extremely stable, because we want to make sure when we put it into the device, it's supposed to be clinical information, should work reliably. And we had to realize when I'm also involved in very many perfusion studies right now with a few doctors, so I'm also having a couple of hundred data on that already. But we see that we need some more iteration rounds before we will implement it into our device. That is a situation as of now.
Marcos, just to make clear what he's talking about, he's saying that pulsatility perfusion is not working. The dream is over, but not the perfusion with saline.
Yes,
Saline is
exactly.
working very well.
Yeah.
Saline is working very well, and the question is how to make the software stable in all conditions. Because, just to give you two examples. First is that we need central line. We tested in peripheral line, it's impossible.
It's diluted already on the way to the heart.
Because we needed really a bolus of salt, of sodium, passing through the lung. Because all the mathematical formulation is based on bolus of infusion, so first passage of contrast. So has to be almost instantaneous, maximum 2 seconds. So it has to be boom. Secondly, if the patient has one of the challenges is how to subtract the cardiac area, because
Yes.
first the salt goes to the heart and then to the lungs. And then after you are used, it's very easy to say, oh, this is heart, this is not the lung. But to give this information to an average physician would require a lot of training. And the challenge for the software is how to make it 100% faulty proof, so no mistakes, that is going to work in all the cases. Okay, and then I think we both are working hard. We are expecting to have the final approval of the CE in the middle of this year, but this is still a challenge that we cannot promise.
You have to do clinical studies on that,
Yes.
for sure, right?
Yes.
Yeah. So maybe later on we don't have to do clinical studies anymore.
Yeah.
Because
Yeah,
it's, well.
But it's going to be, you have to do preclinical. I think we are going to try a bench, then a pig study, and then clinical. Now everything oriented to this. And then maybe we are not going to be 100% quantitative, but we are going to be qualitative, which is good enough for instance to say, oh, there is high likelihood of thromboemboli, or there is absence of perfusion here for sure, so I can be 100% sure.
Yeah.
I think.
And I mean, I completely agree. Probably we should start with just talking about the distribution of perfusion and the calibration method to make really a quantitative measure out of that is even more challenging, of course.
Yeah.
So I think we should start with just comparing the shapes of the tidal images with the perfusion images first. Yeah, I also agree.
Yeah.
It's probably
No,
the best way.
And it's interesting, if you go to the CT and you see how they do perfusion studies, it's still a very, I was surprised to see that even in the best machines, you take a GE or Siemens, it's still dependent on the operator. You have to put the cursor here to track the pulmonary artery, so it's not fully automatic. So it's a challenge to do this.
Yeah.
Yeah. And the injection of contrast is completely synchronized with the machine, something that at the bedside you have to do by yourself. So,
Marcelo, one question that I have, if I may ask, when you detect in the perfusion image the heart, would you say you simply cut it away? Because,
no, this is the most. It's easy to cut it away.
Yeah.
But then you're making.
But then even the ventilation image, you have also to cut it away, and then you cannot compare it anymore with the normal tidal images, right?
Yes.
Yeah.
But this is, so I would say that then we are thinking some months ago, okay, let's make it this kind of gray zone, and let's give it high certainty about the rest, because the rest we can be 100% sure.
Yep.
Because typically in this zone, what we are going to see is that there is one first flash, which is the heart, because the saline is in the right ventricle. And then it goes to the lung. And then there is a second hit here, which is the perfusion of those very basal or apex parts of the lung that you don't have the heart. And you have almost the two parts of the lung touching the mediastinum. And then, so there is a very tiny perfusion here that you cannot ignore.
Yeah.
So this is a challenge.
What is your recommendation? Where would you put the belt when you want to look at perfusion? At the same level that, like, you just look on the ventilation?
I think has to be the fourth. I think has to be the fourth.
Yeah.
Yeah.
And that is very interesting. Then, even though you definitely put the belt, and that is what the tidal images show you, you put the belt position above the mediastinum, right? Theoretically, but you still see this strong effect from the injection through the passage through the heart.
Yeah.
That is, but you're absolutely right. Of course, if you put the belt higher, then you certainly have at the same location where the passage through the heart is displayed, you still have ventilated lung tissue that you want to observe, because especially when you want to detect over distension
Yes.
with the compression of the capillaries, then you have to observe this area. So you simply cannot just cut it away. That would be too easy, right?
Eu tenho uma pergunta. Eu posso levar pela
Boa noite, obrigada pelo tempo de vocês. Professor, você teve alguma experiência com verticalização? E se tivesse essa experiência com os pacientes verticalizados, como seria a impedância desses pacientes?
Eu vou responder em inglês para
Yeah.
she's asking.
Eu não entendi.
She's asking if we had some experience with verticalization. I suppose that you're talking about putting the patient like in a table and then making like this.
Okay.
We didn't do this, but we did lots of studies elevating the head from 10 degrees or supine, going up to 60 degrees. Okay, and all the time. No, not all the time, but I would say the first thing that we observe that is very interesting is that every patient should have an individualized decubitus. Because, for instance, it's clear that some patients have the best compliance at 10 degrees, and some patients have the best compliance at 30 degrees. And then, this is one point. The second point is that typically you see a biphasic response. Compliance increases a little bit up to, let's say, 15 degrees, then it starts to decrease because of overdistension, because you start to have, your diaphragm goes downward, downward, downward. And then finally, in some patients, if they are obese, you start to see a drop in FRC again because of the compression of the belly. So putting the patient like this is not productive for all of them. In some of them, it's much better for the lung to keep it at a lower decubitus. So this is another part of the story of the EIT that I like it very much.
And I have just one single case example that actually was here in Sao Paulo last time when I was here in 2016. I went either to Albert Einstein or Syrio-Libanese, I'm not sure about that, but there was a female patient, 35 years old, with a cardiac failure. And actually she had this kind of ventilation distribution like you see here. And then the doctor was suggesting to put the patient completely in an upright position in this dedicated bed that I actually have never seen before. So that was basically secured, of course, with a belt, not an electrode belt, but other belt. And then I predicted that if you have this kind of ventilation distribution, there's no potential for recruitment. But they still wanted to do that, so it took them like 10 minutes to prepare the patient and to lift it up. And when we compared the different stati of the supine position with the standing position, as I expected, there was not any change in the ventilation distribution, which I actually was absolutely surprised, because when you should probably see any kind of change, but in this one single case, there was no change at all. And if people would have trusted in ERT, probably, they wouldn't have done this maneuver in this particular patient. But for me, of course, it was very interesting to see if whether or not there would be a reaction on that. Might be that, and then, of course, it's also very much depending on the belt position. Proning, for example, is also very important because of the three-dimensional shape that you basically keep a good distance from the diaphragm, because otherwise the belt captures the reshaping of the diaphragmatic position, which is three-dimensional, when the patient, for example, is proned. So what you say about intercostal space, 4, at the most maybe 5, that is really the best position to take. Thank you for the question.
One question here
Yes.
that came up. is it possible to predict the prone position with the IT before to prone the patient? Yeah.
Yeah, yeah. Would you?
Absolutely, and we are using this now all the time without having, let's say, the final study is showing this. But every time, like in the previous patient, that I see this patient with a dorsal collapse, no ventilation in the dorsal part, and you have already challenged this patient with some PEEP that is relatively high, like 18, 20, and you still see this is the perfect patient to go to prone because this patient is going to gain a lot. And it's very nice to see on the trends how much you start to reverse and having more ventilation in the dorsal part. And I have already this response because we are doing a study using CT and EIT. And you know these initial slides from Luciano Gattinoni that when you turn the patient prone, immediately the consolidations goes down. Absolutely not true. Some patients, they keep dorsal consolidation for hours. So it takes a long time. And this is why some patients, just a few hours of prone is okay. And some patients need a long, prolonged prone. So I think this is another nice aspect of EIT. You can monitor the dorsal regions and check how much is improving along the time.
And I think if I got you right in your presentation, you know I'm not speaking a lot of Portuguese, but a little. So I think I understood something. You mentioned that when you observed that when proning patients, you very often see overdistension in the part that was also previously collapsed, right?
Yes.
And that's also matching with the observations that I have. You definitely, I think you said you can reduce PEEP typically by 6 centimeters of water or something like that?
Depends on the also in the Trendelenburg that the patient is doing.
Sure,
So,
yeah.
so the average is 2, but some patients you have to reduce by 6.
Yeah, yeah. And also of these kind of cases, yeah, it's definitely, and that's not only true for COVID patients, it's generally true for prone patients. Yeah. Yes.
Hi, thanks for the presentation. We tried using the Pulmovista in a patient last week. It was very difficult to ventilate, and we could use the first screen, and I could see the purple spot, and it really was a pleural effusion. However, we couldn't reach that screen with the graphic analysis. Which are the steps needed for reaching the graphic analysis?
The one that is presented here, you mean?
Yes, yes.
It's depending on the software version, and you have to get a new software version. We introduced this view in 2017. However, due to the ANVISA registration, it took a long time to get approval. Right now it's approved, I believe. Yeah, so right now I think you should definitely get an update. And the good thing is when you actually have recorded your data, because you can record your data, you could actually review those data also either with a device in a simulation mode, like we do it right now. I can also provide you a software version for your PC, which is identical to this version. And I don't know if you managed to install it already, but I sent you the software.
Yes, I downloaded, but I couldn't.
Okay. 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 Let me know if you should have any issues. Okay. So we can. Okay, great. Yes. Yeah, okay.
They have the new software?
They already have the new software.
Yeah.
And this patient was last week, right?
Yes, yes, right.
So basically, we have this option now. So first of all, we have this monitoring view. Then we have a second screen where we enlarge the image. Just, for example, if you have doctor rounds, you want to present data, I can actually show it here, how it looks like. So we basically can we actually use this large image also for biofeedback. For example, during chest physiotherapy, we can use it as a biofeedback device. Patients really like it because they have nothing to do all day long. So they like to have this television of ERT and in order to motivate themselves to maybe take a deeper breath from time to time. It's really good. We have no study about that, about any kind of systematic improvements, but definitely it doesn't hurt to do that. And then last but not least, then we did not talk about today because today the subject was electrical impedance tomography, but we also have the way to monitor transpulmonary pressures with Pulmovista right now. So we can attach here a little box that I could also show you, but as I said, it's not the subject of today. And then you can monitor airway pressures, esophageal pressure, and gastric pressure with 3 different pressure ports. And then we have a dedicated view how to display it. I don't think we have time for that today. But last but not least, this view that is shown is the last one. It's called Diagnostico. Yeah, I think something like that. Oh yeah, it's also a good idea. I forgot that we have now 2 different sources here. So basically this is, so we have to go to Vistas. And then this is the last of 6 different views that we provide. And the last one is called Diagnostico. Yeah. And then with this view, if you open that, basically we always have 3 different choices. So initially, we just focused with this view on assessing the PEEP maneuver as we have demonstrated today. So that is the second analysis. Then after the ARCH trial, we thought, oh, maybe it's good to have this direct combination of changes in lung compliance and changes of the lung volume. So that is what we now call Recruitability. And for any other maneuvers, because we wanted to have a view which is usable for any therapeutic interventions that you do. We also have this kind of personalized view, and I can quickly just show you. So when you don't do a PEEP trial, but I will use this PEEP trial to demonstrate. If I do this view, my keyboard doesn't work anymore. Basically, we display the same information, except now we have a different reference. With the Costa approach, we have a reference which is rather a virtual one. So that is the best compliance for all the pixels, but it cannot be achieved in reality because different pixels would require different PEEP levels. And here we basically take the first, in this case, the highest PEEP as a reference, and then basically we just display the change of compliance. And in this patient, for example, the best compliance of the respiratory system was actually achieved at the PEEP level of 8. And that is something that you can indirectly see here, because here you have the largest difference between the compliance win and the compliance loss. So the compliance compared to the reference increased here by, in total, 8%, which is a 21 minus 13. And that kind of approach then can be used for any kind of therapeutic intervention. And this is also the view that I'm using for assessing proning of the patient, supine versus prone, these kind of things, because there you also do not have a PEEP trial. Okay. But you have to check if you just press Vistas, if you get this Diagnostica view presented. Okay, then it's there. Yeah. Okay.
Nice.
Okay, I didn't know that that your device was so close. Sorry. Yeah. Yeah. Okay.
Mais alguém?
Can you just go back into the vistas?
Yeah. Oh. Yeah.
You pressed here. Or directly here.
This is just to select the view. And when you want to open the preparation tool, then you press here. So basically, this is to select the view, and here you basically then open it. That is exactly this button here.
And what we discussed that we can change orders is here, right?
That we can change?
Orders. The order of the
Yeah. 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 Okay. Any further questions from your side?
Acho que aqui no auditório não, no online também não. Então, acho
Online,
que
não
podemos
também. Ok.
Posso fazer uma última?
Claro.
Só uma pergunta para o professor Marcelo. Existe algum plano de fazer um novo art trial, só que agora com a impedância?
Existe, mas acho que vai demorar ainda uns poucos anos aí pela frente, porque acho que é uma questão de, acho que nem tanto de recurso, mas de ter um pouco mais de experiência com alguns problemas, por exemplo, durante a fase de desmame, sabe? Eu agora estou um pouco obcecado com essa ideia de que a gente não pode fazer um grande trial antes de fazer vários pilotos, tá? Porque toda vez que você vai para o multicêntrico, você faz compromissos. Aí você fala, isso aqui não vai dar para fazer para todo mundo, então tira fora. Isso aqui, e aí você vai ficando com... Então a gente precisa ter um pouco de experiência, o que dá para tirar fora, sabe? Por exemplo, esse trabalho aqui que a gente fez agora, eu adoraria fazer multicêntrico, mas antes disso eu queria entender quais componentes da estratégia são os mais importantes e que não pode compromissar. Porque o ART claramente foi isso, né? Por exemplo, você quer ver um compromisso que foi horroroso e tem a ver com o que ele falou? A PIP mínima era 13. Só porque para diminuir o trabalho das pessoas titularem várias PIPs. Então, ninguém usou menos que 13 de PIP. Aí, a gente percebeu que você pega um paciente oriental e magro, 13 equivale a 24 para ele, sabe? Então, assim, o paciente oriental, ele tem o tórax platiforme, assim, oblongo, né? Bem achatado no sentido antero-posterior. Então, muitas vezes a gente vê que a melhor PIP dele é 3, sabe? Então, e aí a gente tem muito indígena no Brasil que tem esse mesmo tórax e eu acho que o ART foi aplicado assim de uma forma muito, né, que a gente deveria ter feito alguns pilotos antes.
O Proceva levou 40 anos, né? A Prona para provar, né? Até
Exatamente, é um ótimo exemplo.
Que se beneficia, como fazer, né? Eu acho que chega lá também. Eu acho que sim.
Essa é a ideia.
A questão a gente vê qual é o melhor paciente, qual a melhor forma. Né?
E querendo ou não, diminuir volume corrente e pronar são relativamente mais fáceis do que titular PIP.
Sim, concordo. 100%.
So, and if I got you right, you were talking about the Asian people, right?
Yes.
Which have a smaller dimension, and so the PEEP can be very low.
Exactly.
I just would like to mention you were asking for another art trial, kind of based on ERT. We have already 2 studies, but it's not really small studies, but single center studies, which already have tested in China this assessment as compared to to a low inflation maneuver, best respiratory system compliance, and they found already a reduced mortality of 6%, which is a lot. However, it was a small patient population, so it was still not statistically significant. But right now, the people in China are actually doing something that is kind of comparable to the ART trial, even though not with 1,000 patients, but maybe 300 patients. It's a multi-center trial, and they assess recruitability before they do the recruitment maneuver. And now the study has been started in January, and now we are waiting, anxiously waiting for the results.
I like it to know.
So, well, I will like it if the results are good. You never know. we already had lots of surprises with the multi-center trials in the past, but I believe I've seen the study design and it looks really promising. It's exactly the way I actually would also design such a trial, because I think it's so important to test recruitability before, as we just demonstrated. And they also, of course, use this Costa method. Yep.
Nice.
So, I don't know, maybe 1 or 2 years, hopefully we see new and exciting results.
Perfect.
Let's see. Would be good for us, good for the
Yes.
ERT, good for all those who want to optimize PEEP.
Então, acho que podemos encerrar. Foi uma noite longa e a gente poderia ficar aqui horas ouvindo vocês dois, não tenho dúvida. Agradeço à equipe do 9 de julho pela oportunidade de reunir esses dois grandes nomes e poder apresentar um conteúdo tão rico e que significativamente fez uma diferença enorme para os pacientes. O Dr. Carlos pediu, inclusive, né, se eu pudesse frisar, ele disse que vocês, utilizando aqui, tiveram uma redução enorme nos casos mais graves e tiveram um índice de mortalidade baixo durante a pandemia, um dos mais baixos do Brasil. Então, sem dúvida, é uma ferramenta disponível e que faz a diferença para a evolução de um paciente. Então, sem dúvida nenhuma, agora com muito mais informação, com muito embasamento. Então, obrigada a vocês pela presença, por se manterem aqui, as pessoas também no online, a gente conseguiu segurar uma boa parte da audiência até agora, então é a prova de que foi realmente uma noite muito, muito interessante. Obrigada, Dr. Marcelo.
Legal.
Thank you, Eckhart. Obrigada.
Yeah. Obrigado também.
Foi um prazer tê-los aqui. Então, uma boa noite para vocês. Vamos ver qual é a próxima, né, Dr. Marcos?